Hello, everyone. I hope you're doing super well. Welcome back to Karan Academy. Today, we'll be starting off our rheumatology series with a brief lecture on connective tissue diseases, but more importantly, talking about antibodies, what they mean, what they do, and how we use them in our clinical practice. So firstly, I think it's a really good idea to start off by having a good understanding of what these million antibodies are, because you will be coming across them time and time again, whether it's on the wards, in your exams, or on your quizzes and so forth. So what are these antibodies? So this is me talking about your ANAs, AMA, ENA, anti-Smith, SCL70, all these weird names, right? I think we learn them and we often learn what they mean and what disease they correspond to, but I don't think we do a good job of understanding what they are. So I want to preface this by saying this should not make any sense to you. None of these words should mean anything to you. If they do, you're doing a really good job and you probably are an absolute gun. But if you don't, that's perfectly fine. And that's the premise of the next 20 minutes. All that this means is that within your body, something has happened and you are now producing antibodies against something. Now, the organelles that you're producing antibodies to obviously would be different. And based on the organelle that you are producing antibodies to, we'd call them different names. But instead of just calling it antibody to this particular organelle, like a riboprotein, we add a different name or we call it something else, which is where the confusion arises from, but don't let that distract you from what they are. Okay, so you firstly would be on your rheumatology rounds, or you have a particular connective tissue disease you suspect, you then go ahead and order certain antibodies. So what are some of these antibodies that you order? The most common one you'll encounter is the ANA. Now, the ANA stands for anti-nuclear antibody. All this test does is tell us, does your body or is your body producing antibodies for something within your cell nucleus? Okay. When you get this test back, you get two particular findings, two readings. The first is the strength, and the second is the pattern. The strength is described in the form of a titer, which means at what level were they able to pick this antibody up. So that's 1 to a certain number. So 1 to 80, 1 to 160. The bigger the second number is, the stronger the result is. Well, the reason or the logic behind that being you were able to dilute the sample even further and still pick up that antibody. So it's probably a stronger, it's present at a stronger level than the counterpart. So let's say a 1260 finding is highly positive versus a 1 to 160 is marginal. The second thing that comes back is this thing called pattern. So we tag these antibodies and we are able to often see how they attack the nucleus, right? So antibodies, the basic premise of what they do is attack certain parts. So based on this distribution, we can call them different names. We can call them a speckled pattern, a linear pattern, and each pattern is equivocally kind of correlates to certain diseases, but you don't need to know anything about that, apart from the fact that an ANA includes a strength and a pattern. ENA is where I think things get a bit more complicated. Now, the ENA stands for extractable nuclear antigen and is basically the next step from an ANA. The ANA just tells us that there is something in your body that's attacking your nucleus. It doesn't tell you what it is. It doesn't tell you the organelle within the nucleus being attacked. However, the ENA can. And therefore, the ENA basically tells us whether there are antibodies to particular parts of your nucleus. These antibodies can be to a wide range of nuclear organelles. These can be antibodies to the raw ribonucleoprotein, La ribonucleoprotein, small nuclear ribonucleoproteins, topoisomerase, as well as certain cytoplasmic proteins. Now, you don't need to remember these names, but in a minute, you'll understand why these are relevant. So very simply, we could have just said that person X has an antibody to the raw ribonucleoprotein, right? That would be relatively simple. But instead of doing that, what we've gone and done is given each of these antibodies a special name. So instead of calling it antibody to raw ribonucleoprotein, we'll just call it anti-raw. Likewise, we have anti-La, we have anti-Smith or anti-SM, and Smith is named after the person who discovered it. The antibody to topoisomerase is called either anti-topoisomerase, which makes sense, or anti-SCL70, which I don't know how that relates to topoisomerase, but they're the exact same thing with different names. And then certain cytoplasmic proteins are just called anti-Jo. So this is where you'd see a wide range of connective tissue diseases. Through the course of this lecture, I will mention these antibodies and tell you that some of them are related to some connective tissue diseases. So when you hear that, just know that if I say this tissue disease is associated with anti-Ro, it means that in that connective tissue disease, you would find antibodies to the Ro ribonucleoprotein on an ENA, or an extractable nuclear antigen. That's all it means. Okay, so don't get too confused by that. Now then the question arises, if I tell you that anti-Smith antibody, anti-SM antibody, is particularly linked to systemic lupus erythematosus, or SLE, in a very high specificity, which means it's very specific for lupus, then the question arises, well, why does SLE particularly target this ribonucleoprotein? I could go ahead and tell you, but in all honesty, it does not matter, and it's not something you need to know unless you are a budding rheumatologist deep in your training. So we're not going to talk about that. What we will rather focus today would be on, firstly, inflammatory muscle diseases, systemic sclerosis, Sjogren's, SLE, and then very briefly touching on mixed connective tissue disease and RA. I talk about RA more extensively on our lecture on arthritis, where we kind of go through RA versus OA and how we would clinically differentiate them, treatments, and so on. So let's start with inflammatory muscle diseases. As mentioned earlier, and as you can probably imagine, your immune system has now attacked your muscles and they will be inflamed. Therefore, a myositis. There are a few types. You have polymyositis, where you have inflammation of mostly the proximal muscle groups. So this would be kind of your shoulder girdle, hip. You would rarely see distal muscle involvement with this, but it can happen. And these are usually aged 35 plus. You then have kind of polymyositis, but also a skin involvement, and that is called dermatomyositis, as the name suggests. And that is aged 5 to 15 and 35 plus. So it has two kind of a dual distribution. And then you have inclusion body myositis, which involves both proximal and distal muscles. The name inclusion body comes from the inclusion bodies that are seen on muscle biopsies, which is the go-to diagnostic test for these. I'd like to just briefly mention, I talked about how all of these would present as a myositis, or inflammation of the muscle. I want to very briefly compare that to what a myopathy is and how the two are different. So a myopathy is muscular weakness. Myositis is inflammation. So with a myopathy, like steroid-induced myopathy, you will have weakness but no pain, right? Because the muscle is weak but not inflamed. Versus in all of these conditions, you would have elevated inflammatory markers. Typically, you would have pain. You might have some redness with a skin involvement, but they would be very different to your typical myopathy picture. Symptoms would include weakness, as I mentioned, but more importantly, the ones we really worry about are the symptoms of proximal muscle involvement. So if you have muscles of your esophagus being affected, you might present with dysphagia, as well as asphyxiation because of poor coordination between your epiglottis, your esophagus, and your respiratory tract. Finally, you can have respiratory muscle damage with failure of the diaphragm, because that too is a muscle, right? And they would present with respiratory failure. And therefore, in a lot of these severe cases, they would be under close respiratory monitoring. You can also have Gottron's papules and a heliotrope rash. And that, because these are skin manifestations, these would obviously fall under dermatomyositis. And these are what they present like. So these are Gottron's papules, and this is a heliotrope rash around the eyes. A muscle biopsy is the gold standard test. As I mentioned earlier, the CK, or the creatine kinase, would also be elevated because it is a byproduct of muscle breakdown. You can also use antibody testing, so anti-Jo1 as well as anti-Me2. If you remember, anti-Jo is the antibody to certain cytoplasmic bodies. And therefore, with these inflammatory muscle diseases, you would often see in basic human terms, your body's producing antibodies to certain parts or certain organelles within the cytoplasm. That is what this means. Dermatomyositis often also presents with solid organ malignancies, and I think this is more relevant for your examinations, your end of year exams, where they might mention kind of this inflammatory muscle picture, solid organ malignancy, but hopefully you should also pick up on the fact that there is skin involvement, which, as I mentioned earlier, would be most typically one of these two, so Gottfried's papules or a heliotrope rash. You can also do an EMG or nerve conduction studies where we can identify how the muscle is contracting through the form of an electromyogram. Other differentials you need to consider when someone presents with this pattern of weakness and potentially pain. Firstly, would be fibromyalgia, and particular skin manifestations of fibromyalgia include cafe au lait spots, which we'll go through later. You can have polymyalgia rheumatica, which typically presents in patients above the age of 50 with pain and weakness in the shoulder girdle as well as the hips. And then they can also have a myopathy, which is typically hypothyroid or a steroid-induced myopathy. But remember, a myositis should always be differentiated or different to a myopathy. Next, you have systemic sclerosis or scleroderma. Now, what's happening here is that your immune system has decided to attack your skin's connective tissue. Over time, elastin, which, as you can imagine, is responsible for ensuring the elasticity of your skin, will be replaced with fibrin, which is a byproduct of inflammation. This will eventually lead to thickening and hardening of your skin, and you'd lose that elastic component. There are a few types of scleroderma that you need to know. The first is limited, and the second is diffuse. As the name suggests, limited would be inflammation that's limited to the skin, the pattern being mostly peripheral to proximal. And then you have diffuse, where you have earlier internal organ involvement. Diffuse is less common, but more deadly. The one thing you need to know about scleroderma are the kind of associated features with it, and that is the acronym CREST, which we will talk about. Some cutaneous manifestations include, as I mentioned, hardening and thickening of skin, sclerodactyly. Because of this now hardened and thickened skin, you now have almost a fixed deformity because of the skin tightening. You can have atrophy, telangiectasia, which are these more prominent superficial blood vessels, and what is called a face of no expression. This is because you have significant tightening of the skin around your face, and they often have an emotionless appearance. It's very hard to describe, but if you look at a picture, it does seem to be quite striking. In terms of vascular complications, Raynaud's is a big one, and then you have a higher risk of thromboembolic phenomena. In terms of CREST that I mentioned earlier, more associated with limited scleroderma, it refers to calcinosis cutis, which are these subcutaneous deposition of calcium. You then have Raynaud's, esophageal dysmotility, because you have a similar process going on within the esophagus. And with the displacement and deposition of fibrin in the esophagus, you would lose its good rhythmic contractility. Sclerodactyly, as I mentioned earlier, and telangiectasia. Now, the one thing that this always looks like to me is gout, because gout also presents with these kind of weird-looking whitish colored lesions. The thing you need to know with calcinosis cutis is that this is a subcutaneous deposition, and as you can see, it's not over the joints, versus gout, which would typically arise in the joints and extend outwards. That's an important point of differentiation. And here you also have a picture of sclerodactyly. As you can see, the skin is very tight and it's shiny, and you have a fixed deformity. As it progresses inwards with diffuse SCC, or systemic sclerosis, you can have pulmonary fibrosis, exact same concept with the deposition of fibrin with the inflammation. You can have arthralgia, if that's happening in your joints. Scleroderma can also lead to a sclerodermal renal crisis, because you now have large levels of collagen and fibrin depositing in the kidneys, which obviously is not good. And if you have that same deposition happening in the heart, again, it would lose its ability to expand and fill, leading to restrictive cardiomyopathy. At the time of diagnosis, therefore, we want to rule out all of these manifestations. We do a UEC to check for kidney function. We do a renal ultrasound to check for flow. We'd like to do an echo to check for cardiac function and to rule out a restrictive cardiomyopathy. And then we can also do antibody testing. Now, you have anti-centromere that is seen in limited SSC and anti-SCL70 or anti-topoisomerase that's seen in diffuse SSC. The way I remember this is anti-center, so it's not in the center, it's everywhere else. It's in the skin and it's not central. Anti-center, limited, meaning mostly in the skin. Diffuse is just everywhere. Next, we have Sjogren's. Sjogren's is a very common autoimmune condition where now your immune system has decided to attack your parotid and your salivary glands through a lymphocytic infiltration. So these glands are quite heavily involved with lymphatic circulation as well. And you now have increased deposition of lymphocytes. This also increases the risk of non-Hodgkin's lymphoma because with these lymphatic tissues, which are now undergoing high levels of lymphocytic deposition, you increase the risk of any of those lymphocytes turning malignant. And if you have a malignant transformation within the lymph node, that's called a lymphoma. It's typically seen in middle-aged women. It presents with a triad of 3 particular areas, and these are mostly secretory functions. So xerophthalmia, which is dry eyes, xerostomia, dry mouth, as well as vaginal dryness. Particular antibodies positively present in Sjogren's are the anti-Ro and anti-La antibodies. The treatment is purely supportive and symptomatic. So we will provide them with artificial tears for their dry eyes, artificial saliva, or provide a muscarinic agonist, which would help increase the rate of salivary function, and also advise them on using lubricants during sex. Then we have the big one. This is the most common, probably, and most notorious connective tissue disease that you'd probably see. It is systemic lupus erythematosus, or SLE, or lupus. It's always the diagnostic answer for any house episode for my house enthusiasts out there. It's more common in women, and it has an incredibly wide range of presentations, which make it really hard to diagnose and really hard to treat. So some important features that you should always know. Firstly is the rash. So you have a malar or a butterfly rash. Secondly, you can have alopecia. Other ones, I've mentioned a whole bunch, but the ones you need to know: malar rash, alopecia, Jacquet's arthropathy, which is very unique to SLE. It is an arthropathy that is reversible. So with RA, you also have deformities of the fingers, right? In the form of an arthropathy. But the arthropathy seen in RA is erosive and therefore non-reversible or non-fixable. You can't just pull that finger back to look like it did earlier. Versus Jacquet's arthropathy is non-erosive and commonly involves the tendons surrounding the finger, and therefore can be reversible. Other complications would be lupus nephritis, would probably be the biggest one, and therefore all patients with SLE undergo yearly visits to the renal clinics. And in terms of treatment of SLE, with most rheumatological conditions, there are a few medications, all immunosuppressants. The first one is steroids, which is your stock standard immunosuppressant. It is really good at treating all inflammation, but is best used in the short term. Longer term use, as you would know, can lead to a wide range of complications that is too long to cover in this lecture. Other medications include mycophenolate mofetil or Mycept. You can also have azathioprine being used, as well as hydroxychloroquine, which is an anti-malarial. All of those medications are also commonly used with renal transplant patients. So we're going to do a quick rapid fire, which you can hopefully come back to if you'd like. just for a quick revision on antibodies. So anti-Jo1, anti-Me2 are associated with polymyositis and dermatomyositis respectively. Anti-centromere antibody seen in limited systemic sclerosis. Remember, anti-center, meaning in the skin. Anti-SCL70 is the other one seen in diffuse systemic sclerosis. Anti-Rho and anti-La are the ones seen in Sjogren's. The way I think of this is probably not a good memory tool for a lot of people, but Rho in Hindi, Rona means to cry, and anti-Rho means they can't cry because they can't produce tears. And La just sounds like singing, so they can't really sing because they've got a dry mouth. So if that helps you, then great. If it doesn't, I'm sorry. If it doesn't, I'm sorry. If you have an ANA positive that's speckled with a dsDNA and an anti-Smith, that is going to be SLE. One point I want to make here that I skipped over earlier is the difference between diagnostic and continuous using of antibody testing. So your ANA, if you use it once to diagnose a condition, you don't use it again and again and again to assess severity. Versus your so your ANA, if it's positive once, then great, you make the diagnosis and you move on. You don't repeat it. Versus dsDNA, when used for SLE, is a good marker of its severity. And therefore, if someone has an acute relapse of their SLE, you might often order a dsDNA because the levels of dsDNA closely mimic disease activity. And this is not the case for ANA, but is for dsDNA. And then you have U1RNP, which I've almost rarely seen used in clinical practice or in exams, is specific for mixed connective tissue disease. I hope that was useful. If you have any questions, please feel free to get in touch. I'll be more than happy to answer them. But if not, best of luck, and I'll see you next time.